Okay, that's lovely. Anyway, and I will open up my slides. The most important thing is, I suppose, that you can see the slides. So yeah, look at that.
They were able to see the slides. Will they
Yeah.
podcast?
It will. This will just be running in the background, and I'll run it as a slideshow. Okay.
That's good.
So, right. So my topic was adolescent gynaecology, and it's a really big wide topic. So I've just focused on a few little bits, but I'll be talking about a case that I saw in a month ago first. So. Right. So is 11-year-old girl. She flew to A&E on an early Sunday morning, as they all do, at 2 a.m. with a history of sudden onset vaginal pain over the preceding 3 days, gradually increasing in severity until her presentation. It began at school on Friday during PE. She told her mother at home the lace of underwear was hurting her, and she was going to cut off all the lace. So her mother just says she thought it was a bit of thrush, gave her canister cream to apply to the area. Next day got worse. Her mother discovered she had not been applying the cream and encouraged her to keep applying it. She couldn't sit comfortably the whole day. On Saturday evening, she was having a shower and she ran out crying, and she said it was excruciating painful. The mother examined the area and discovered this. Now, this is not LM, because this is just an area of a bulge at the one side of the labia, and on LM, it was gangrenous. So the whole thing it looked like a big bone, basically. So where do I come in? I was sitting at the A&E desk, writing up my notes after reviewing another gynae patient. Pizza sister comes to me and she says, "Will you please, have a look at this? I have no idea what's going on." So I happily printed off that question. And after consent of both Helen and her mom, I just looked at her intimate area. There's just a swollen bulge in the labia majora, about 0.5 to 1 cm. It was all black, with a long strand of hair from my head. She was very long, like longer than mine, nearly waist length hair. Anyway, so the hair from my head that was wrapped very tightly around the base of this bulge. It was very, very painful. There's a small non-discharging punctum at the left area bound by the hair around, say, 4 o'clock of the bulge. No discharge, no bleeding, no erythema, no visible trauma marks, nothing else around the area that would ever arouse any other suspicion. It was very, very, very shy, very tearful, uncoordinated. There was a very weird tension between the child and her mother. And everyone picked it up almost immediately. The A&E trash nurse was a woman. The initial A&E trash nurse was a male, and she wouldn't engage with him at all. So he transferred her over to another trash nurse. Peter's sister and me were both women. So basically, there's an unremarkable medical, social, surgical history. She was the youngest daughter. She's in this class, and she's doing very, very well in school. In terms of puberty staging, she had not had menarche or dolarche, but she had a little bit of puberty as well. So she was in early puberty. So we went outside. We decided to inform both our regis about what happened because we had no idea what to do. So the pizza session was really strongly suspecting sexual abuse. Our other differentials were mole, and the hair transplants came, which was what it was. So Pete's reg came, and it was a big burly man, so he didn't go near her at all. And our reg, another nice lovely lady, she came, had a look at her, examined her. So we both stood at the end of the bed, and we examined her from that distance. And we sprayed local anesthesia on her hand. She said that was fine. We then sprayed on the inner thigh, not directly at the area, and then she just jumped off the bed and started screaming and crying. She's like, "No, this is painful. My arm hurts. I don't want to do it." So then we were like, "Fine, there's nothing more we can do here. We'll need to examine anesthesia or something. We're going to nurse." So she admitted the LM and the pediatrics and all the consultants, which reviewed them in the morning. So she was reviewed by the outstanding consultant in the morning. She refused to examine the anatomy again. She refused to interact with him and just physically moved away. So the decision was made then for EUA plus minus proceed for a proper exam, diagnosis, and management for exactly what's going on. Police consultant, who was a lady, came in the afternoon and decided to do the management with us for the EUA. And I allowed the female consultant to explain the area briefly. So there was just excision of necrotic tissue at the left labia majora for the necrotic skin area. And that's the OT pain. And she was well. The next morning, she was discharged without any follow-up. So I suppose learning points for us was that if at all sexual abuse is suspected, we should escalate to senior management immediately, and this should be done by the A&E triage personnel instead of us blundering about. And as per the Department of Child Health, the Children First guideline, there's a lot of things that that we should be doing. Keeping them in a room by themselves, special forensic examination, the GARDA and everything needs to come in as well to have a look at them and talk to them in a very child-friendly environment, and just to be sure that it's not sexual abuse, because this is one of the differentials when a young girl presents with something like this. And according to the HSC's CARI protocol as well, good practice. And this is just the guidelines. So a lot of it, I don't know about them, but you need to involve the GARDA too, and specialized community pediatricians afterwards. So basically, what exactly is Hannaton-Gay syndrome? It's just a strangulation of the appendages by a thread of human hair, which will lead to ischemic injury of these appendages. Typically involves the digits and genitalia of children, infants, children, and as here we have adolescents. It's very uncommon, but it has been described since 16th century. Around the digits of babies by their mother's hair. This is because postnatally they lose a lot of hair due to hormonal imbalances. So the infant just gets the mother's hair, plays around with it, and then gets stuck around the digit. But in terms of penile tourniquet syndrome, that's thought to be a form of control of nocturnal enuresis, and legal and control wrapping as well is seen in an older age group then. So it's just basically secondary obstruction of the venous outflow and arterial perfusion by the hair that's wrapped very tightly around the area of skin, cutting off all supply. And the longer you leave it, the longer it's a positive feedback. So the longer you leave it, the longer it's worse, and it just gets necrosed at the end, finally resulting in autoamputation in the worst case scenario. Right. So the diagnosis is always based on the clinical findings. And now the other differentials are inflammation, allergy, a bee sting, maybe contact dermatitis, swelling from something else, trauma, abuse, self-identification with hypoxia. This includes infant child masturbation as well. And you will have a low threshold of suspicion in children with disabilities or limited communication ability, trichomania and such. So, because it can always result from child abuse, they should always be excluded first. Other proposed theories, as I mentioned earlier, self-infliction and an attempt to control nocturnal nemesis. Usually non-specific, but there'll be a lot of pain, they'll be crying if they're younger, and like this girl, she's just completely uncommunicative. She didn't want to talk to us about why the thing was there, she had no idea what was there. On physical examinations, a lot of erythema and swelling. So your management is immediate removal of the hair thread, use fine tooth forceps and scissors, and you cut it off. And they mentioned using depilatory creams as well, but you should use this in cases where there's no skin breakdown because it's going to affect the skin. And explore the area as well for additional scans. Complications include ischemia, soft tissue injury, infection. Flexion deformity is a complication of digital cataract syndrome, but not in this case. So more learning points, I suppose you should have a lower threshold of suspicion for developmental delay behavioral disorders when you see this in the A&E. And like I said, postnatal mothers with delusion effluvium should tell them, expect that to happen, and just to make sure their babies aren't playing with hair. Check the infant stitches every few days. Their clothing should be laundered from inside out to make sure there's no hair strands stuck inside. And avoid using gloves and mitts on their digits, so that if there is ischemia, it doesn't get worse and you don't know. So with LM, I suppose if her mother had recognized it earlier and brought her into a sooner, we could have stopped it from necrosing, but we had no idea. And the examination of anesthesia may be the immediate best management for all internal injuries in children, especially children. In the A&E, like I said, prompt notification by professionals to senior members on call, not enthusiastic as it was. Like you have time is brave for stroke, you have anesthesia for this as well. So this brought to mind how different adolescent gynecology is from the usual gynecology that we deal with. And we never really see many gynecology patients as well. I mean, adolescent gynecological patients as well coming to the A&E for one thing. So you need to be very sympathetic. You need to be very empathetic, in particular in dealing with them, because it's this could lead them to have trauma that they'll remember on and on for a longer time afterwards. And she may have been more open if we had been more tactful, and we would have saved all the intimate examinations for the most senior decision making, clinical personnel instead of us first. That's what always happens in A&E. And adolescent girls are always under a lot of pressure, so this leads to a lot of other problems as well, which may manifest in different ways. Menstrual dysfunction is another one. Examination performance can lead to a lot of stress, as you know. And so complex and rare medical conditions can also occur, must not be missed. Some congenital disorders present for the first time in adolescence. Early detection and appropriate treatment in adolescence ensures the best possible outcome in terms of sexual function and potential fertility. There was no RCOG, HSE, or NICE guidelines for adolescent gynecology that I could find, so I just had to look up a lot of different things. Basically, what is normal in a prepubertal child that hasn't gone through puberty yet? You have a mucoid vaginal discharge of the anterior vaginal introitus. You'll have a hymen, a small uterus 2 to 3 cms, called the epithelium, and the cervix will be a bit red if you look at it with the pediatric spectrum, of course. The adolescent female will have similar characteristics to adult female, with plus or minus a hymen. The change from a hypoestrogenic to a hyperestrogenic state of the vaginal epithelium makes it more resistant to infection, and children have more prone to infections because of the lack of estrogen. The mucosa implications and such. So always use a pediatric speculum if you have to in examining the young child, and keep them like in a frog-like position, which is basically the child on the mother's lap, the legs up, or the knee to chest position as well if you want to examine the child. So vulvovaginitis is the most common gynecological complaint in the prepubertal female. This is just pruritus or erythema, bleeding if they are scratching too much, and redness of the introitus. This is, like I mentioned earlier, the thin mucosa, lack of labial fat pads, proximity of the vagina to the anus, and lack of hygiene, poor hand washing, and hypoestrogenic state, tight clothes, and the urine reflux into the vagina because small space. Your differentials would be UTI, eczema, scabies, conjunctivitis, pneumonia infection, foreign body, which is usually just toilet paper. Psychosomatic complaints, prolapsed urethra, but just ensure hygiene, no other measures involved really other than just make sure the area is moisturized and not dry. And some vaginal discharge is normal, but unusual ones like the yeast infection might be good indication for further treatment. Lichen sclerosis is another one which you just see a lot in prepubertal females about to reach menarche. A lot of itching, a lot of itching, and you will get a little plaque formation around the labia, and the perianal regions as well. No one knows why. Contact dermatitis makes it worse. But topical steroid creams need to be used just to prevent scarring and then a lack of tissue architecture loss. That's permanent. And I missed something. I missed vaginal trauma.
Backspace.
There we go. Vaginal trauma. So TAS abrasions, ecchymosis hematomas, very common in pre-adolescent girls, and this is higher than 4 and 12. And this is a vaginal tear here. This is stratal injury, genital events. But your other differentials, most importantly, are sexual abuse again. Accidental penetration, this could be benign. Sudden abduction of the extremities and pelvic fractures as well. So use a vaginoscope to visualize the vagina and repair all aspirations basically. And antibiotic therapy afterwards to prevent STIs if this is sexual abuse. So I'm not going to go into a lot of detail with the hypothalamic pituitary axis, but just to remind you that you basically have an increased production of LH and FSH hormones and leptin, which initiates the whole cycle. The growth spurt obviously begins before the absence of puberty. This is usually 1 year before menarche. Menarche refers to breast development. Adrenarche and pubarche. Adrenarche is production of androgens. Pubarche is pubic hair. And usually you get pubic hair first before breast development. And menarche is vaginal bleeding, which responds to hormonal changes. And you have that in consular menses, was the WHO definition of 1987. 12 to 13 years of severe nowadays, but that hasn't been scientifically proven. So, abnormal pubertal development, you can have delayed puberty, estimates by 16 years, absence of breast development by 13 years, precocious puberty, which is by 10 as well, secondary sex characteristic occurring in a girl for the age of 8, 9 for boys, or the onset of menstruation prior to 10 years of age. And that's another one. Primary amenorrhea, failure to menstruate at the age of 16 years. And this is very important if a girl has menstruated by 16 years to make sure there's no other underlying congenital defect as well that warrants further investigation, gonadal failure, endocrinology, a lot of endocrinological syndromes. 60% congenital, 40% endocrinological in origin. And not really going to mention about all of the different types of syndromes. Secondary amenorrhea is the absence of menstruation, which can be temporary or permanent. It can be in girls who exercise a lot and a lot of stress as well. But an important thing to look out for in girls who haven't had their menses for about 6 months is PCOS, which is another one that we see very commonly in adolescent girls, and pregnancy, of course. So obviously pregnancy test in the young girl. So menstrual disorders. So you have what's normal, and then the first few menstrual cycles during menarche may be anovulatory due to an immature hypothalamic pituitary axis. So this causes severe dysmenorrhea, severe menorrhagia, which leads to absenteeism from school and everything. But then adolescents with chaotically irregular cycles within 3 months should be evaluated. I'm not really sure if it's normal to have irregular cycles in the first few years, but it does happen. Other causes of irregularity include, like I mentioned, pregnancy, and if they have an underlying chronic disease that makes them like vulnerable to disease, something like that, or asthma even makes them more prone to having irregular cycles. Endocrine disease, Cushing's, PCOS, hypothyroidism, premature ovarian failure, CAH, congenital adrenal hyperplasia, genetic disorders, acquired conditions, stress-related, medication, exercise, eating disorders, and tumors as well. Ovarian tumors, again, tumors, prolactin tumors. So dysmenorrhea is a very common complaint that a lot of young girls come into their GPs and then refer them to us for as well. This is because of the increased prostaglandin production of menses in normal anatomy. Secondary dysmenorrhea results from endometriosis and anomalies with obstruction in the portion of the outflow, leading to pain in the obstructed segment by the blood. It may or may not be affected. Examples include the obstructed hemiuterus, other anomalies such as diabetes with the obstructed hemivagina. I get very severe cyclic cramp-like pain below the pelvis, and associated with the menses, of course. This radiates to the thighs, to the back, and your first line treatment is always prostaglandin inhibitors, this is what's causing the problem. And if they're not adequately managed by that, then you may think about oral contraceptives, obtain a pelvic ultrasound to see if there's any abnormality like the ones I mentioned above. Depending on the progression is greatest. And so laparoscopy is recommended if the medical treatment fails to control all of this. And menometrorrhagia is just irregular bleeding. And this is usually self-limited and resolves the maturity of the HPO at the same time. Otherwise, you need to think of PCOS, and the measure is just cyclic hormonal manipulation with progestins or combined OCPs. However, obtain a pelvic ultrasound to outlook PCOS. What is PCOS? So, if a teen presents to you at the A&E or the gynae clinic with hirsutism and complains of heavy bleeding and very regular cycles, you need to think of PCOS. They may also have campus nigricans, treatment-resistant acne that Redrick hasn't worked, scalp hair loss in a Christmas tree kind of pattern for females, hyperhidrosis. These are not always present, but they contribute to the diagnosis. So this has lifelong implications, which is why it needs to be picked up early and treated early as well. In terms of this is the most common cause of infertility in a woman. They will develop metabolic syndrome, type 2 diabetes, cardiovascular disease, endometrial carcinoma in the long run. It's poorly understood, but it basically circles around hyperinsulinemia and childhood obesity. So you have your biochemical diagnosis, which is serum testosterone levels, sex hormone binding globulin below, HbA1c will be high, serum prolactin, and DHEAS, which is dihydroepiandrosterone sulfate, which just tells you that basically, your organs are producing a lot of androgens. And then you do an ultrasound and you find an ovary that has a volume of more than 10 mils, are follicles more than 12 in either ovary, between 2 to 9 millimeters. And what you do is you regulate the cycles. The cycles P's diet is the most commonly used for PCOS in this country because it is anti-androgenic. It attacks all the other HER67 and anti-symptoms as well. And creams for the hair. Metformin is kind of like if there's abnormal glucose tolerance and the grading, you don't start that in adults and anyway. So the logic for COCP is that the progesterone component inhibits endometrial proliferation, and the estrogen component then reduces the excess androgen, which corrects the natural abnormalities and kind of restores it to back to normal. So that is that. And beyond today's scope, congenital anomalies, many neoplasms and ovarian tumors, ambiguocytomas, AH, progetic sensitivity, sexual mutism, but delayed post puberty. But I just try to focus on what you would see most commonly in the A&E and in the gynecology as well, like the most common referrals from GPs. So thank you very much.
Thank you. I think the point you made earlier on about who we examine when is actually important.
Yeah.
Because as an 11-year-old fronting up an A&E, something down below is a nightmare for the girl. And having a succession of adults, male and female, queuing up to come in saying, right, I'm the next one to have a look, is not ideal. So you want to minimize the number of examinations and so on. Having said that, I think, particularly as a female, and if you chat to the mother and her and you get her confidence and sort of say, can I have a quick look and have a chaperone there, is not unreasonable. You may sort of go, okay, I'm not really terribly sure. And it might just be an infected hair follicle and you know that's pretty clearly what it is. I think what I'd probably do before doing that is to ring the reg and say, look, I've got this 11-year-old, she's got a pain down below. I was going to have a look. Do you want to come and be there at the same time, or will I have a look and ring back to you? If the reg you say is a male, then if you've examined it, there's something funny there, don't like the look of it, doesn't look straightforward, then the reg should probably contact the consultant rather than saying, look, my turn next, sort of thing. And the consultant says, I'll come too. And it may be that the consultant and the reg walks in and the girl goes, in which case you go straight to the UA. Okay? You wouldn't attempt to do anything else at all. But I think it is very much a case of just keeping it in mind, am I the right person to do this? And even if I think I am, I might just ring the reg just to say, is it okay if I go ahead and have a look at this first? And if it's a fella straight up, it's probably a good idea to sort of go, there's a fair chance I won't make a diagnosis here, I better pass it. And if you're the SHO, I'm the reg, and he's the consultant, well, you know, you're snookered straight away, she's not going to get a female, in which case you may end up moving it up the line and chatting to the mum and saying, look, somebody's got to have a look, and if she goes, no, we're not doing this, then you have to go straight to an EUA. And again, probably reasonably soon, because you need to know what is going on here. But it's tricky. But there are times where, with the benefit of hindsight, you go, I suppose really I should have passed this up the line sooner. But I think in a lot of cases, it may be something quite simple. And even though you might be very experienced, as a female, you have an advantage. You can get her trust. And she say, oh, my that lady having a look at me, and the fellas outside go with some face. And it's just being in tune with that. And again, getting the connection with the mother. Now in this case, you're sort of on some weird relationship. Now it may just be that the girl's stressed out and the mother's stressed out, and the girl's stressed out, and it's a standard family mother-daughter thing, and maybe not. But again, you've got to engage the brain and go, is there another agenda going on here and something else? And that's where again you get the PEDS team involved. And there's the child first guidelines and so on, where you have to sort of say, look, this may be something simple, but I might have to make a call. We had a case in theatre a couple of years ago where there was a little girl came in with some rectal bleeding, and they did an EUA theatre, the surgeons did, and I was asked to come and have a look, and the anal sphincter looked disruptive to me. And I immediately went, right, I don't know what this is, but I know what this potentially could be. And where do we take this? And I went straight to nursing admin and said, look, I think we need to get the child first guidelines out here. And this, I'm not saying we need to report this, but we need to treat this very carefully. And we need to, and as it turned out, she had some sort of a GIT disorder which had caused this, and it was perfectly simple and benign. And I was able to tell them that the hymen is intact, there's no damage from a gynecological point of view, but you could certainly see that the sphincter didn't look quite normal, and you wondered had there been penetration and tear or something else. But actually it was a function of some pediatric GIT disorder and such. But you immediately set all the protocols in motion and get the relevant people. Because the bottom line is, with child abuse and with adolescent gynecology, for most of us, we go, I kind of studied that the night before the exam and managed to forget it the night after the exam, and it's not something we see a lot. But when you have any, and it also is important you have an index and a level of suspicion for it, because you just need to get, and you need to be careful you don't swing in the other direction and have too high a level of suspicion. But you need to sort of say, I'm not 100% convinced everything is as it seems, and on that basis, where do I escalate this to? Who do I talk to? When they say, look, I'm not 100% happy, I need a second opinion, there might be some other things going on here, and then to treat it very sensitively and carefully.
I just have a question, because if you were just happened to a friend of mine here in the hospital actually, where there was child abuse suspected, how do you go about documenting that? Because what happened to in this case is the child was seen in peace for chest infection. In the non-examination, there was what the nursing staff also thought as abnormal amounts of bruising on the child. She then went ahead and documented that there is maybe suspected, but then this generated incident reports against her.
Okay. Now, I think, to me, I would document factually what I see.
Yeah.
That there seems to be a lot of bruising, no clear explanation at present, may need further investigation. We'll talk to my registrar and so on. And I would verbalise my concerns to my registrar without writing down possible child abuse needs to, the guards need to be contacted, nursing admin, and it's written in the notes. And then, as you say, that then comes out. And then if the parents come back, can we see a copy of our notes? All of a sudden, well, you're almost guilty until proved innocent, sort of thing.
Yeah.
So, I think initially I would just document factually what I see and say, look, query coagulopathy, query other problems, we'll discuss with the registrar.
Okay.
And that's why I'm saying it's very appropriate to have an index of suspicion, but it's very important we don't jump in the other end and say, right, get the parents out of here, we need to get a social worker, and this child's going into care. You completely go overboard and say, until you can prove to us that this isn't child abuse, you're not getting back into this room. So that's the difference. And when you're out of your comfort zone, that's when you start to, and especially as you were saying, at 3:30 in the morning, the brain sometimes is a bit scrambled, and you sort of look at it after the next day and go, in hindsight, I might have not written this or not done that or said that. And I think always just before you even write anything, maybe make a phone call to a senior and go, I'm just not 100% happy with this. Do you want to? What should I do? Do you want to come and have a look before I write anything down?
Okay.
So, while child sexual abuse is always, you have to think of it and consider it as part of differential, it's actually rarely the cause. With your scenario and with this scenario, again, it was documented in the notes, query sexual abuse, and I think one has to be cautious about that, because the parents will come back, look at the notes and say, well, that was never an issue, and get pretty upset about it. And then about referring up the line, and when I saw this particular case, it was very obvious what it was. And normally I'll say, if you phone me about a patient, I want to know everything. This is probably a case where you phone me before knowing everything, okay? In the pediatric scenario, because it should be sort of at a senior level, the examination together, rather than repeated examinations. So if you phone me about a 29-year-old woman at 30 weeks with ruptured membranes, and you haven't examined her, and you'd say, oh, I'll go back and I'll see, and oh, I don't know about the stillbirth, the last pregnancy, I'll just hang up and ring me back. This case, I would prefer hands off and do as little as possible. But what you can do is take a comprehensive history. Okay, and there were clues in this mom's history in that, it was just there for a few days. There was no complaints before that. The mom thought, put some creams, but it got worse. And the mom said there was a black area there, and she thought something might have been wrapped around the tissue. So listen for the clues, okay? And a lot of the clues were there. I think between the dynamics and the mom and the kid, it's hard to know in this scenario. Refer up the line straight away. You won't see that many pediatric cases. I haven't seen that many pediatric cases. Very few. So it is a learning experience, but there's very few. So get someone senior from the outset. Okay? And when I saw this, it was very obvious what it was. It may not be so obvious to someone else. Okay? And so from 2 points of view, you need to get the trust of a young kid, and it very much is age dependent. So when they're toddlers and stuff like that, it's not as much of an issue, but when you're sort of pre-pubertal, pubertal, post-pubertal, you really have to get their trust. And what's unclear to me is the psychological impact of a little girl on future, from numerous people having a look and saying, look, oh well, we'll have a look and we'll see what's going on, and then how that might interact on her sexual development in the future. I've no way of knowing that, and it's hard to gauge, but there is potentially, if because when I came to see this little girl, you don't know the dynamic, but she certainly didn't want anybody else to talk to see her or anything. So you've got to get their trust and hands-off approach. So really the focus here is the history and an appropriate timely examination. All right. And that's important for a second reason, is that if there is any query about sexual abuse, I've been trying to do even less. The reason being that if there is sexual abuse, there is a possibility that you'll break the chain of evidence. Okay, and that if you go comparing and looking and stuff like that, that there may have been some evidence there that's now been interfered with. Okay, so if in doubt, yes, contact someone else. So Dr. Sharon Condon, who's the pediatrician here, is the coordinator for this region for child sexual abuse and queries child sexual abuse, and she deals with all the kids under 14. Where there's any concerns, and if in doubt, contact her and contact the appropriate people. Okay, as I said, it won't be that often. If in doubt, or even if someone presents to you in your general practice or referred to the gynae clinic, it's usually more of an elective scenario there. But if there's any clinical suspicion, someone in A&E, contact the appropriate people and say, look, because when you have someone for the investigation of child sexual abuse, it's very different where the police and a police examiner are involved, and they get the kids to strip off on a sort of a paper thing, and they take samples of hair, they comb out the pubic hair if it's there. So there's all that side of it, and I don't know the exact things that are done. Dr. Condon would be aware, and I've asked her to come maybe and give a talk about what she does as well. But the police need to be involved and all of that. If you're not too sure about how to do it, and I don't know the exact way it's done, but you need to make the inquiries. So this really is one scenario where I think less is better as regards the examination. In this case itself, here tourniquet syndrome, it's not common. It's very obvious what it was. It's her own hair had wrapped around a piece of her labium and it had become necrotic. So a mole, it did look like a large mole, but again the history is that it's only been there for a few days. So it's very unlikely that you could have an acute mole, right? Sometimes you can get sort of like a vulval varicosity, and that might look like a little black area, and that's what the mom said. Just a little black area on the tail. You know, sometimes you see it in pregnant women, these little vulval varicosities. She might have, there was no history of trauma, and one person had described it as looking like a raisin, and that was a very good description. It looked as if someone had put a raisin on her labium. And you think, well, what could have caused that? And you know, take a comprehensive history and then reflect on what do you think could be going on here. You know, will sexual abuse cause this area that's acute? Unless there was a hematoma, you know, then probably not. The hematoma might be more extensive. And this is very rare. It was very obvious what it was, but I had never seen it before. It's interesting to look at the dynamic of this hair tourniquet syndrome, and you know, it happens in kids, whether it is done electively by parents, let's say to take off moles or skin tags, you know, which is sometimes the case, whether there's a cultural element to it, it's difficult to say. And then teenagers, and I couldn't really elicit from this patient either whether it was accidental or whether the patient had just been doing a little bit of an experiment and maybe wrapped some hair around it maybe. And you don't know whether that's the case. Did you find that in your reading? Whether
No, that never came into it.
No, never came into it.
The etiology of children of adults and females and why they end up leaving.
You know, but so in your reading, did it come up at all as regards why this happens? This hair tourniquet.
Self-infliction was one thing.
Yeah, but that's what I'm saying, self-infliction, and whether it was self-infliction in this case or whether it was purely accidental, and that's difficult to say. You know, she's probably a bit, in my opinion, maybe a bit too young for self-infliction. Might occur more in the older kids where, oh, here's my genitalia, I'm not happy with it. And even though they're perfectly normal, it's more in the older teenagers. And you're seeing it a bit more where there's more requests coming in for can you do a labial reduction or something like that. And one has to be cautious about doing it. I think as well, like, part of the issue here is that mom might have been a little bit upset with herself or felt a bit guilty.
Yeah,
And if she came in on the Friday, then you might have just been able to unwind the hair and the tissue might have been saved. She, and you know, this is only a personal opinion, maybe felt a little bit guilty that had waited till Sunday and now the tissue hadn't necrosed. And it's very simple to deal with. You just cut it off and bring back the labia and it'll heal fine. It should be a little bit sore, but that's all. You mentioned about the pediatric speculum.
A small one.
Yeah, even be very cautious about putting any speculum near any kid, particularly who's not sexually active. So obviously it's very sensitive, again, taking a sexual history in a teenager, because it might be consensual, but it's not legal. Okay, under 16, so you have lots of teenagers now who are sexually active at 13, 14, 15, 16, and if they're sexually active, that may be fine. Then you must be cautious about whether to chat to the kid on their own always with a chaperone, or should the parent be there? Okay, and you sense some dynamic about this as well. Because the older teenagers may not divulge anything with their parents there. And if there is an abuse, the parent might be the abuser. Okay? It is and that's most commonly in child abuse to someone known to the patient. Okay? So what they do recommend is do nothing and take the kid for an EUA, or you have the ENT instruments. So the ENT instruments are like the things for holding open the nostril. An otoscope, so these tiny little scopes that you can just place through the hymen and have a look, rather than pediatric speculum. Pediatric speculum are actually quite big for a teenager or a pediatric case, or the tiny neonatal laryngos type of scope, where they're tiny blades, and you're just literally opening the labium to see whether it's a foreign body. And you touched on that, and one of the most common presentations is a foreign body. It's often kids just experimenting with themselves. I remember my own kid. Here's a pea up my nose, Dad, and I put another one up after it to see if that one would get it. And they just stick things in places, and little girls stick things in there, just experimenting. And sometimes it's very easy just to tiny little tweezers and you get it. But it's usually best done under examination, under anaesthetic. In young kids, older kids may tolerate it, but because you won't see this very, very often. I've only seen a handful. There was this case. There was a number of cases of trauma, and that's exactly it. Usually on a fence, borrowing their mother's bicycle, or having a bicycle that has the bar, and they land on the bar, and it causes an abrasion. I remember seeing one case of a concealed pregnancy in a teenager, and she came in bleeding and had a tear, and she totally didn't divulge anything in her history, but a delivery was very obvious from the point of view of what you found on examination. So that had to be referred to police, because you're dealing with delivery. The baby had been just concealed pregnancy, hidden at home, and she was traumatized, but the kid had died. I think they're the main points. Any questions? It's very interesting.
Yeah.
Thank you. Good. In this sort of what they've moved away from is sometimes skin tags. They just put a tie around skin tags, and they eventually fall off. But they moved away from that as well as where there's post-axial polydactyly, and even not full polydactyly, but sort of a remnant of a digit. And they used to put a tie around it, but now they surgically remove it, and it's a little bit less painful. Yeah. And it doesn't cause any harm. Polydactyly is just it's not normal. Yeah. Good. Thank you.